I'm Sally Kochmar, Laboratory Manager for the Magee Women's Hospital Medical Genetics and Genomics Laboratories in Pittsburgh and AGT's Director of Education, and it's my pleasure to welcome you to AGT's webinar series. If you're not currently an AGT member, please consider joining the organization. The membership money helps to fund the webinars such as these and many other activities such as giving us a voice on the CAP proficiency exam committees and the ASCP Board of Certification, amongst others. So please consider joining. This is a great organization for technologists to meet and interface with other technologists. It's one of the few organizations at the technologist level. So please check AGT's website, www.agt-info.org, to see the many benefits of membership. A few quick housekeeping notes before we get to today's presentation. Please feel free to ask questions during the session. In the upper right side of your computer screen, you'll see a control panel. In the lower portion of that panel, you can type in a question or a comment and submit it to the webinar organizers. You can do this at any time during the presentation. We'll reserve about 10 minutes at the end of the presentation for questions and answers. If you're participating as a group, please designate one person in the group to complete the online evaluation. In order for everyone to receive their certificates of attendance, the person will need to enter the names and email addresses of each person who's participating at your site today into the evaluation. As a backup measure, you can also send a sign-in form to AGT and fax it in to AGT as well. Certificates will be emailed to participants approximately 30 days following the webinar. Today, Dr. Daniel Bellissimo will discuss pharmacogenomics, personalized drug therapy based on an individual's genetic makeup. Dr. Bellissimo is co-director of the Pittsburgh Clinical Genomics Laboratory. He is board certified by the American Board of Medical Genetics in Clinical Molecular Genetics and has directed a clinical molecular diagnostics laboratory since 1996. His areas of expertise are bleeding and clotting disorders, including von Willebrand disease. His current interests include using high-throughput sequencing, interpretation of sequence variants, and pharmacogenomics. Welcome, Dr. Bellissimo.
Well, thank you very much for asking me to speak today. So on the first slide, I'll give you a brief outline of the talk. I'll start off with a brief introduction into pharmacogenomics. Then I'll use some specific examples to illustrate how genetic variability can alter metabolism and efficacy of drugs. And I'll use a couple of examples I'm most familiar with. And during that, I'll also demonstrate the challenges in implementing pharmacogenomics into clinical practice. So pharmacogenomics has been around a while, but it actually got a good shot in the arm with the Precision Medicine Initiative that Obama introduced in 2015. So this provided funding for projects that would help accelerate biomedical discoveries and provide clinicians with new tools, knowledge, and therapies to select which treatments would work best for which patients. So that's clearly like a pharmacogenomic type of project. To enable new era of clinical care through research and technology and policies that empower patients and researchers to work together. Again, a lot of implementing pharmacogenomics is really going to take research and studies that require this empowerment of patient and researchers. So it was clearly directed at those kinds of changes, and also to change the culture of medical practice and research to kind of engage, patients as collaborators in this work versus just being subjects. Okay, so that's really a new thrust in pharmacogenomics. So why the focus on medicines? It's clearly one of the bigger targets and one of the easiest to approach in this area. First of all, we know a lot about the biological and shared pathways and targets of drugs and how they work. They're very easily measured phenotypes, measuring drug levels and responses to them. And we know that there are germline sequence variations in the population that are quite common that affect the metabolism of the drug, so it can have a high impact on a lot of people. The testing is feasible. A lot of the molecular technology makes this very more straightforward to do. And there's also fewer ethical concerns here because we're not testing people and screening them for genetic diseases. We're screening them from common markers that just affect the way they respond to drugs. So one of the problems is with medications is they often don't work for everyone, and that's illustrated in this quote by Dr. Alan Roses, who is the VP of GlaxoSmithKline, in that the vast majority of drugs, more than 90% of them, only work in 30 to 50% of the people. And that's illustrated in this diagram where you can see in the number of different common disorders, it's quite common not to have a drug work more than 30 to 50% of the time. So the real question is, can we get at why some patients respond to some drugs and others don't? Can we use that to put them on alternate therapies, or can we use it to change the dose or something that would help us make these drugs more effective? So the main problem with treating patients equally is that, we tend to do the averaging of finding in an average population what's the best dose that would give us the efficacy we want that's also safe to use. But the problem is, in the population, we have people who respond differently to the drug. And so when you apply, go back to this. And so when you apply the average this dosing theme to people, what happens is that you have some people in the population who are very sensitive to the drug, and the average dose is going to severely overdose them, and it could be an extreme safety issue. And then you have other people at the other end of the spectrum who they're not very sensitive to this drug, and they're not going to get a very good response to this drug at the average dose. So again, the question is can you identify these people? Because we know 30 to 50% of the people do not respond to drugs. And so why are people so interested in this? It's not only just patient care, but also, we all know that the cost of drugs is really, really expensive. And what this graph is just illustrating is the amount of money being spent on prescriptions, and we can see that that cost is rising. Drugs are getting more and more expensive. So it makes sense to try to find a way to use them the most efficiently we can to care for patients. So there's been a really emergence of pharmacogenomic data for a long time. As I mentioned, this field is not new. It started, way back. There are publications back to 1965, but you can see that in the past 10 years or so, the amount of publication and work in this area has really been expanded. So our knowledge is really expanded. There are a number of different consortiums and groups working together to consolidate information. This PharmGKB and the CPIC, which is the Clinical Pharmacogenomics Implementation Consortium, are collecting lots of information on responses to drugs. There are 21 different genetics-guided drug therapies covering 35 drugs, and there's many more that they're collecting information on. This just shows you a group of the drugs that are probably the most common pharmacogenomic markers. What I want you to see here, mainly, first of all, that there are genes involved in the metabolism of different types of drugs. We see CYP2C19 is involved in the metabolism of clopidogrel, but also antidepressants. We see CYP2D6 is involved in the metabolism of pain medicines and also the antidepressants. So you can have different effects across different drug groups. And also the recommendations that can come out of pharmacogenomic testing can go anywhere from, completely avoid this drug in a certain patient, to using an alternate therapy, to using dosing based on genotype. So it can have a big effect. I just want to point out there are some, HLA can be an important marker, a pharmacogenomic marker, because it affects people's immune response and their sensitization to certain drugs. And that's why you see examples of people with certain HLA types having to avoid drugs. So pharmacogenomic information is on a lot of medical labeling already. There are greater than 140 drugs that have genetic data included in their FDA approval product labeling. Most of the time this is making you aware of the genotype information. It's not always it can recommend, it doesn't require kinds of information. You can see these drugs form the gamut of all different kinds of areas, but the biggest one here is in oncology. I did want to take a real brief sidebar because I'm not going to be talking about in this talk. I'm mainly going to be concentrating on germline common variants in the population that affect drug response, but there's some very good examples of personalized cancer therapies based on specific somatic mutation status. One of the best examples is in Philadelphia chromosome-positive patients, where these patients have a 922 translocation that forms a novel BCR-ABL kinase. And imatinib was actually one of the first molecular design drugs made to inhibit this kinase, and has had incredible responses in the treatment of Philadelphia-positive patients with this drug, but it only works with the Philadelphia chromosome-positive sections. There's an example in non-small cell lung cancer, where patients who respond to this drug, gefitinib, the ones who respond are the ones who have mutations in their epidermal growth factor receptor. So that's a really important part of testing their tumor to see if they have those mutations, and then they can be treated with this drug. And then there's another example in melanoma, where it's the patients who have BRAF, valine 600 to glutamate mutations that respond to this drug for merfatinib. Sorry, I mispronounced that. I'm just going to leave it there. So it's important to recognize overall that pharmacogenomic markers can have effects in different places. We tend to think a lot about where it affects in metabolism, but it can affect bioavailability, that these drugs have to be absorbed in the GI tract and metabolized, and then they go to the liver, in which they're metabolized again and then put out into the circulation. And once there, then it's mechanism of clearance. How long does it stay in the circulation? How is it metabolized and transported and excreted via the kidney, but also in the circulation? You know, what's its distribution, and how can it get into the CNS? Can it get across the blood-brain barrier? So all these are places in which there could be a pharmacogenomic marker that affects one of these processes. And overall, we're looking to see, you know, what is the efficacy and toxicity of a drug based on all these mechanisms. So here's just a list of the major drug metabolism genes. You can see that they're all CYP genes, and I'll explain in just a second what that is. The different gene systems that have sequence variations in the population that affect their activity, there's a red box around those, and right now I'm going to concentrate on these three in yellow over here, and we'll be talking about these in the talk later. One is to notice in CYP-DC19 that the different sequence variations of the population lead to a decrease in activity in this marker, but when you go to 2C19 or 2D6, you see that there's both increases and decreases. And what this is indicating is that a drug can be metabolized to an active form, and so, or a drug can be in its active form and then get metabolized to an inactive form. So a variant that would decrease activity, let's say decrease 2C19, if the drug is metabolized to an active form and there's decreased activity, you would get a decreased amount of that active form, and you would be underdosed. Whereas if the decrease is in the metabolism of an active form, the decreased activity would lead to higher levels because it's metabolized less likely. So you can have different drugs going through different pathways, so the same sequence variation can cause an increase or decrease in sensitivity to the drug depending on which drug it is. Okay, so cytochrome P450s, these are play an important role in biotransformation metabolism. A lot of xenobiotics, so drugs and chemicals in the environment, as well as also steroid hormones and bile acids and vitamins in our body. But they're greater than 400 of these isoenzymes and 36 families of these genes. And just the nomenclature we'll see around, you've already seen this in the preceding slide, but the CYP is for the cytochrome. The next number is the gene family, then the subfamily, and the individual gene name, and then we might have a star designation for the actual allele. So this example, CYP2, 2 is the gene family, the subfamily C, the individual polypeptide family is 19, and we're talking about the star 2 allele. And the star nomenclature is very similar to what you see in HLA, in which that star indicates an allele that's either a specific sequence variation or maybe a set of sequence variations that define that allele. And typically the star 1 allele is usually considered the wild type allele. So most of these cytochrome P450s are located in the liver and the endoplasmic reticulum. That's where most of the metabolism occurs. They're heme-containing proteins, and you'll see this picture of the kind of a structure of this protein with the red indicating the heme and the iron in the middle. And it's this heme iron that's responsible for the absorbance at 450 nanometers, and that's why the name, that's where the P450 comes from. That's the absorbance of this heme group in this set of proteins. Now, as we mentioned, they play a key role in biosynthesis and catabolism. So the first drug we're going to talk about is clopidogrel. It's also known as Plavix. So this is used for post-percutaneous coronary intervention. So basically after a myocardial infarction, putting in a stent to open a blood vessel is a very common place this drug is used. It's absorbed in the gut, and then it's metabolized to its active form in the liver. So this is one of those ones that's going to be transformed in the active molecule. And then that active molecule can bind to platelet, this receptor, P2RY12, and prevent platelet activation. So it prevents clots, but it could also increase the risk of bleeding. So this is the exact metabolism of clopidogrel. This is the prodrug because it's not the active form, and the CY2C19 then metabolizes it as most cytochrome P450s do. There's both a reduction and an oxidation that occurs, and we can see this sulfur group here gets reduced and the carbon gets oxidized, and that's and now this is considered the active form of the drug. So sequence variations that would decrease the activity of CYP2C19 then would lead to a decreased amount of the active metabolite in individuals. So there are a number of different alleles described in this system, and some of them illustrate some very interesting mutation types or sequence variation types. Again, here's the nomenclature of the family. There are alleles. The star 17 allele is actually, this is 806 base pairs in front of the ATG in the coding region. This is a promoter mutation that leads to increased expression of this gene. So this is unique. All the other variations we'll be talking about are loss of function or reduced activity, whereas the star 17 leads to increased activity. We see star 4 is actually a change in the starting ATG at position 1. We have examples of missense mutations. The star 2 allele was actually one of the more common variants in the population. It looks like it would be a benign variant because it does not change the proline at the position 681, but it turns out this change activates a cryptic splice site, which leads to an outer frame protein loss of function. So this is a nice example of why sometimes we ignore a synonymous change where the protein doesn't change, but it actually is a deleterious variant because it creates a splice site. And we have the star 12 allele where the very stop codon of the gene, the stop at 491, gets converted and extra amino acids get added. So again, kind of a bunch of different types of mutations between missense, truncation, splicing, and promoter and initiation codons. So there's a lot in this table. We don't need to look at all the information. Basically what you should see is that the star 1 allele is considered the normal population variant, except for in star 17 is the increased transcription, and the rest are mainly loss of function. The other important part here is I have arrows next to the 3 most common variants in the population. So it's basically the star 1, the star 2, and the star 17, and the rest are more rare. The frequencies I have in this column, these are the percent minor allele frequencies, and so and they're based on the European population, African American, and then all. So you can see that the population, the frequency is pretty similar across the different active groups, and that's an important point, and we'll discuss a little bit more later. You can see this is pretty much even all the way through. But based on these frequencies, we predict that 30% will have impaired metabolism. So we're predicting like 30% won't respond to this drug very well because of that. Knowing these allele types that an individual has allows us to predict their metabolizing phenotype. So we can look at someone who has 1 star, so they're homozygous for the wild type. They're what we call an extensive metabolizer. Then the other end of the spectrum, if they have a 1 allele and a 17 because of the increased expression of 17, we have what we call an ultra-rapid metabolizer. The same is true if you're homozygous for 17. But any of the other loss of functional alleles that are paired with a normal wild type are all considered intermediate or impaired metabolism, and anyone who has 2 alleles with impaired metabolism is considered a poor metabolizer of this drug. So we can easily predict how people will metabolize a drug based on this diplotype. And you can clearly see those results in people if you look at this is just a graph of the clopidogrel concentration, and remember it's going to get metabolized to the active form. So if we look at the people who are poor metabolizers, you can see that they have a much higher level in their bloodstream of the drug than the normal metabolizers, because the normal metabolizers metabolize this to the active form. And then if we go over and look at the inhibition of the platelet aggregation, which is what we're trying to achieve with this drug, you see because the people metabolize it better, they have much better inhibition of platelets than the people who are poor metabolizers. So you can clearly show this effect. Again, one of the points we'll come back to is you can show this an effect here on binding, but can you show effect that clinically makes a change in these patients? So if we look at some of the work that was done initially back in 2009, looking at patients and their outcomes on clopidogrel and then going back and doing their genotype, what you can see is that that people who had 1 reduced functional allele had about a 55% increase of death, heart attack, or stroke, and a 3-fold risk of stent thrombosis. And if they had 2 reduced functional alleles, they had about 3.58-fold increase of death, heart attack, and stroke. And so this led to a warning on the FDA labeling of this drug that you can see an example of one of these below, where it says poor metabolizers treated with Plavix at recommended doses exhibited a higher cardiovascular events following coronary artery syndrome. And that there are tests available to test for this genotype, and you should consider alternate treatment or strategies in these patients. But again, no specific recommendation, just that you can consider. Again, this study was looking backwards. They didn't show that doing the genotype made a change, but they did show that the people with specific genotypes responded less well to the drug. So because based on that evidence, these were the kind of the recommendations that came out in 2010 from the American College of Cardiology and American Heart Association, saying that the evidence base was insufficient to recommend routine genetic or platelet function testing at the present time. There was no information that the routine testing improved outcomes in large subgroups of patients. So that's the important part. Can you show change in clinical outcome? The clinical course of the majority of patients treated with clopidogrel with or without genetic testing is excellent. So overall, people did really well on this drug, even though there's a subgroup who do not. And then genetic testing may be considered in patients believed to be at moderate or high risk for poor outcomes. And so that's a little bit harder to do. How would you do that unless you can identify those without genotyping them? So that led to more studies, and this is a big study going on called the NIH Ignite Pharmacogenomic Workgroup Study. They're looking at CYP2C19 genotype-guided antiplatelet therapy post-PCI, as we discussed before. So in this study, anyone who has a loss of functional allele is going to be recommended for an alternate therapy, and that people who don't have a non-functional allele, they'll get no recommendation, so most likely they'll just do the normal clopidogrel. And the primary endpoint is major adverse cardiac events, MACE. You'll see that in another slide. So, and this is an example of what those are. So they're looking for that primary endpoint. The study is ongoing. This was data that was presented last year at the American Heart Association meeting. Right now that cohort's up to 1,815 people. And as we mentioned before, we'd expect about 30% of the population to have a loss of functional allele. And in this study, that's about exactly what we see. So in this arm then, about 39% of those people got the normal treatment clopidogrel, and 60% of them were changed to an alternate treatment based on the fact that they had a loss of functional allele. And then for the people who didn't have a loss of functional allele, again, the main treatment was using clopidogrel, although some people use an alternate therapy. So right now, this is what some of the data look like. So we're looking at cumulative MACE events, or the rate of these events. And you can see that when you compare, again, these are the loss of function people who got clopidogrel against the loss of function people who got the alternate therapy, you can see there's a significant difference in the number of events that we're seeing, and then the other people who don't have that are kind of right in the middle. But I think it's interesting to note that at this very, very early time point, you see this is where it seems to make a really big difference, the drug they're on, because the rate early on, there seems to be a fast increase in the amount of these events in the loss of function people on clopidogrel, where that seems to be minimized in the people who get switch therapy. So it'll be interesting to see if this trend keeps up. I think that's important, and what this would say is that it's very important that the genotype be available very soon before, as people begin treatment, and so this switch can be made to avoid these set of events that occur. This is similar to a study going on at UPMC that my laboratory is participating in. We're performing the CYP2C19 genotyping for this study, and then we're basically following a similar algorithm that was in that study, in which patients who have a loss of functional allele would the intermediate metabolizers, the poor metabolizers will get alternate therapy, and the people who are good metabolizers will stay on clopidogrel. And this is following recommendations from the CPIC organization. And so we're following these outcomes then in these patients, in these samples, looking at the clinical outcomes, our process efficiency of being able to provide a laboratory result, being able to get it in the hands of physicians and the way they can interpret it and use it, select their medications, again, monitoring satisfaction patients, and also whether this has impact on outcome, not only on the patient's outcome, but also financially, because a lot of times you have to be able to make a financial case that adding this testing will change outcome and the healthcare costs of doing it. So the next example I want to go to is a drug called warfarin. This is a very common prescription in the United States, greater than 2 million per year, and that was a while ago. It's used for the prevention and treating of clotting. It's typically people who have had deep vein thrombosis, pulmonary embolism, or possibly a heart valve could be treated with this. And it works by inhibiting vitamin K dependent clotting factors. I have to give you a little bit of history of this drug, given that I'm from Wisconsin, and that's where it was discovered. Warfarin is named for the Wisconsin Alumni Research Foundation, which supported the work of Carl Link, who was actually studying, along with some veterinarians from Canada, why a group of cows, when they were either neutered or dehorned, were bleeding to death and had profound bleeding problems. And they traced this back to them eating some moldy sweet clover plants, and were able to isolate the compound that eventually was shown to be responsible. It was a compound very similar to the final compound warfarin that inhibited clotting factors. And so it became a rat poison, and then it became a really important medicine in the treatment of bleeding and clotting. So the goal of this therapy is to get what we call the PT-INR. So it's a prothrombin time international normalized ratio. So normally the normal ratio in a person is 1. So we're trying to get someone into a treatment range of 2 to 3. So basically you'll bleed 2 to 3 times more easier, and we're doing that to prevent clotting. And that's the window they try to keep people in. And you'll see a lot when we talk about some of the studies. They're trying to say, compare the time to get you in this therapeutic range, how well you stay in this therapeutic range without any outcome. So you'll see the INR come up in that context. Now, warfarin maintenance doses are characterized by a really large variability in individuals, and so that does make it a problematic drug. It's a good drug in that it works. It's very inexpensive. It's been around a long time, but it has this extreme variability. Maintenance doses can range over 50-fold between people, with a daily dose ranging between 0.5 and 25 milligrams, and that's a huge difference in a drug that could cause either bleedings or strokes if you get it wrong. So that's why it's important to get it in this range. The other important part about this drug versus there are some new drugs out in the market that are warfarin type replacements, but because this is a vitamin K inhibitor, it makes it very easy to reverse the effects of it. So if someone's on this drug and they get involved in an accident and they're bleeding profusely, high dose vitamin K or plasma transfusion can quickly reverse the effects on the clotting factors, which is really important in treating the people. So anyways, the factors, these are the factors that can be utilized to predict warfarin dose, because these are factors that affect warfarin dose. And you can see there are many of them: age, sex, race, weight and height, smoking, the indication, whether they're using it for a DVT or whether they're using it for heart valve. Sometimes there's a different range you try to get someone in. The target IRNR you're trying to put them in. There are lots of drugs interacting. I think I showed you from those other slides. There are certain genes that are involved in metabolizing multiple drugs. So if we have drugs that interact, it's going to affect the dose of warfarin. The plasma level of vitamin K, and more importantly, diet. So someone who, something like spinach, which is really high in vitamin K, and a person who doesn't eat salads very often all of a sudden gets on a spinach kick, that their dose is going to, because of all the increased vitamin K in their diet now, this is really a vitamin K inhibitor, that will affect their response to the drug. So that's a really important thing too. And then there's also genetic variations, in which we'll talk about these. And overall right now, it's thought that genetic factors are about 40% of this, but still a large part of it is these other factors. And this will come up again later when we talk about dose. So this is how warfarin metabolism works. It has two isomers, the R and the S. It's mainly the S isomer that's active. It works by inhibiting this vitamin K reductase, which is going to form vitamin K that's required to make functional clotting factors. So by inhibiting this, there's a decrease in these clotting factors, which prevents you from clotting. So when we look at its metabolism, it's mainly metabolized by the CY2C9 gene. So variants that don't metabolize as well will leave higher levels of warfarin left and make them more sensitive. There's also variants in this enzyme too. Again, a decrease in this enzyme would lead to less vitamin K, would also make you more sensitive to the warfarin. So these are the two most important factors that affect warfarin metabolism. There's another gene that leads to the metabolism of the reduced vitamin K, but we're not going to talk about that one today. So these overall, the CYP2C19 counts for about 18% of the dose variance. Again, it metabolizes greater than 90% of the active warfarin, and the STAR2 and STAR3 alleles are the ones associated with increased sensitivity to warfarin. So they have decreased metabolism, so the levels in these people will be higher, which makes them more sensitive. The vitamin K epoxide reductase accounts for about 30% or so. It's inhibited by warfarin. It's important for the replenishment of the vitamin K, and it turns out this variant in the promoter is associated with warfarin sensitivity. So it leads to a decreased amount of this protein being present. And this is the other gene we talked about, which accounts for some of the dose and is associated with a higher warfarin dose. So these are the variants we're talking about. The STAR1 is the wild type allele. STAR2 has about a 50% reduced activity, and the STAR3 has about 15% reduced. The variants cause reduced activity, and they're associated with a lower mean warfarin dose, a longer time to a stable INR, and a higher risk of bleeding. They're observed in about 20 to 40% of Caucasians, and it's not as common as Asians and African Americans, and that'll be important point for later too. The VCOR C1 variant, again, it's a promoter variant that finds a haplotype that's associated with increased warfarin sensitivity. This is because it leads to a decreased expression of that, and therefore there's not as much as around, and so not as much warfarin is needed to inhibit it. So typically there would be a lower mean dose in these people. And again, it's observed in about 40 to 50% of Caucasians, but only in 90% of Asians, but only 10 to 15% of African Americans. So there are actually dosing calculators that have been formed and quite well tested that can take into all these types of effects on that affect warfarin dose and calculate an appropriate dose for a patient. So these dosing calculators will look at age and sex and weight and smoking status and race, and it can do all those clinical factors with or without the genetic information and predict a dose. And these have been used quite successfully in studies, and I'll show you an example of that. So this was one of the first randomized studies that was looking at, will genotype-guided therapy work better than standard dosing therapy? And standard dosing therapy is usually just starting patients out on a fixed dose, giving them a fixed amount over the first few days, and then manually adjusting kind of what you give them going forward. So what this study showed is the average maintenance dose by specific genotype were significantly different. So what do I mean by that? This is the example from the study, that we can look at the dose per week of warfarin that these patients got. And you can see that when we compare wild type and then patients who have 1 variant, 2 variant, 3 variant, 4 variants, the more variants there are, the lower the dose that they need. And this is a very significant difference. We see about a 5-6-fold difference in dose across these patients. So it was clear that the genotype would predict that you would need, what range of dose that you would need in this drug. It also showed that the genotype-guided dose was more accurately approximated stable dose. So comparing where they started dosing them to where they ended up. So this is what this looked like. So again, we're looking at the change in dose from initial to final. The white boxes are the pharmacogenomics guided dosing against the standard arm dosing. And what you can see is that when we compare in the wild type, you can see that the pharmacogenomic dosing had very little change based on it. Again, it's going to take into account the fact that a wild type person metabolizes warfarin quite well and start them on a higher dose, whereas in the standard arm, they would start them off lower and have to increase their dose to get them up to the appropriate level. There wasn't much difference in the 1 variant case, but once again, in the multivariant case, you can see that the pharmacogenomics arm could predict that these patients would metabolize warfarin poorly and start them on a lower dose, whereas in the standard arm, they had to quickly decrease them from the starting dose to get them in the right range. So it was clear that the dosing calculators would predict this dose and make it close to the final dose better than standard dosing would be. But the study also showed that the multi-variant allele carriers had an increased risk of an INR greater than 4, but the primary endpoint of the study was the percent of time they were out of range in their INR, and there was no difference. So even those differences we're seeing dosing, basically what that means is the clinicians very rapidly, even though with those underdosing and overdosing situations, are quick to recognize that the dose needs to change, and they do it to keep them in the appropriate INR. So they're kind of counteracting the effect of starting off with a dose that's a little bit wrong and then quickly getting into range. So they could not show an important clinical significance of incorporating this into clinical practice, even though they could show that these genotype-guided doses appear to do much better in predicting the dose. So at that time, then the guidelines again came about warfarin dosing. We're not recommending it. So the first one from the cardiologist, again, without evidence from randomized trials, we suggest against the use of pharmacogenomic dosing in patients. The American College of Medical Genetics Work Group said there was insufficient evidence at the time to recommend it, that prospective clinical trials were needed, and direct evidence for its benefits, disadvantages, and costs associated with the testing. CMS didn't believe there was evidence to use it also, so they were not going to cover it for Medicare beneficiaries. But they realized that they had to encourage people to participate in the studies that might prove that was beneficial, so they would cover Medicare beneficiaries who are candidates who participated in a prospective randomized controlled study. So they're trying to encourage people to participate, but no one was going to cover the cost of this testing. It became clear. So this gets back again to the importance of generating data on clinical utility. Does the testing reduce the adverse outcomes? Is it effective in reducing the incidence of high NRs, high INRs, time to stable INR, serious bleeding events, while maintaining the drug's ability to prevent thromboembolism. Are the dosing algorithms accurate for all ethnic groups? That's a question we haven't asked yet. Is it cost effective? And I think one question that probably hasn't been approached yet, even in most of the studies done, is it more effective in a non-compliant patient? In other words, a lot of these studies are closely monitoring the patient's INR as part of this study. But typically what can happen in a clinical setting is that the patient gets sent home on a dose they're supposed to return in 4 or 5 days to have their INR checked, and they don't. And so the question is it possible that the genotyping would help assist you in getting them right, which we have some data that will do, because it's unlikely they'll come back for all the appointments they're supposed to. So that's still another question hanging out there. So there were 2 multiple randomized trials done on genotype guiding dosing, and these actually appeared in the same issue of the New England Journal of Medicine, and there was even a 3rd study in the same issue, but I'm just going to concentrate on these 2, and you can see kind of the frustration that can happen in trying to generate these results. Is that the one study said that genotype guided dosing of warfarin did not improve anticoagulation control during the 4 weeks of therapy. And then the other study was pharmacogenomic-based dosing was associated with a higher percentage of time in the therapeutic INR range than with standard dosing. So here we have 2 kind of conflicting conclusions, one that the genotyping didn't help dosing and the other that it did. So let's take a look at why that may be true. So we can start off by taking a look at what they used as their control group, and these were the 2 studies, one by the COAG group and one by the UPAC. And the UPAC study, their control group was standard of care. So again, this is just a fixed rate of dosing and adjustment that happens. Yet the COAG study used a clinical algorithm as their control. And if you remember, I mentioned in the dosing algorithms that you could use all those other clinical features, and you could use it with or without genotype information. So they're using a clinical algorithm that takes account to all those other clinical factors, which accounts for probably at least 60% of the effect on the dose of warfarin into their control group, where this study is not. So I think that's one hint there of why maybe this group had showed benefits of the genotype where this group did not, because they were, we'll see that a bit below. We can see that the numbers in this study change, and then this is also a very important difference that we'll be going into, and that the diversity of the population tested in these studies is quite different. This one having a very low amount of African Americans, blacks, and this one having a significant amount. So when we look at the results of these studies, did the genotyping lead to a more accurate dose? This study came to the conclusion, yes, but in non-blacks only. And this study said yes, but of course they didn't have enough patients to answer this question that they came up over here. Does it lead to a shorter time to a stable dose? No, and then yes. Improved time in the therapeutic range? This group, no. This one, yes. Reduced number of INRs going greater than 4? No, and yes. And then then on the low side, the reduced number that were below and out of range. Again, no and yes. And this is all because I think they picked an algorithm that accounted for a lot of the different changes and kind of evened that out directly, where this group did not. The other thing I think I really want to stress is that racial differences can be really important in PGX studies, and actually lots of different studies. I've seen this message over and over. This came up in blood banking all the time and blood group analysis, that there's vast genomic differences between the different races. So let's take a look at what's going on here. So again, we have the CYP2, C9 alleles, and we said most testing does testing for star 1, star 2, star 3. We look at the frequencies of the population. You can see that the star 2 and 3s are more common in the Caucasian population than the African American population. But there are a group of other star alleles in this system that are more common in African Americans and hardly present at all in Caucasians. And there's also a sequence variation in this intergenic area, which has also been linked to the metabolism of warfarin, which is very common in African Americans, but also common in Caucasians. And what you can see is that these star 5, 6, 8, and 11 alleles, along with this this SNP here, are more common in African Americans and result in a lower warfarin dose. And at 45 to 50% of African Americans are going to be carriers of one of these alleles, and these are not accounted for in the dosage algorithm. So you might predict that this dosage algorithm might not work as well in that population. We know that to be true. Additional studies carried out by these groups down below showed that the race did affect the dosage changes associated with genetic factors. Matter of fact, it was shown that the STAR2 allele and the V-core effect on dosing is a lot larger in Caucasians than African Americans. So there are other genomic changes that are affecting how much impact these two variants have. Only the STAR3 allele was equally predictive in both racial groups. And this the CYP2C variant, if you remember, it was common in both the Caucasians and the African Americans, but it had a significantly greater effect on dosing in African Americans than it did Caucasians. So dosing predictions that are much improved in African Americans by using this as additional information. So that argues, that we may have more complicated approaches in pharmacogenomics. There's the approach that most have used in that the race combined approach tests for these 3 different markers, and you get a warfarin dose for all. But it may be more accurate to do this race stratified approach where the Caucasians are tested for V-core, STAR2, and STAR3, but in African Americans it'd be more efficient to test for V-core, the STAR3, and the SNP that affects dosage, and we get much more accurate results. I do want to point out when we compare the two studies, the one with very few African Americans in it, I guess knowing this is true now, you can see why they saw a greater impact of using 2C9 and V-core genotyping, because their group was mainly Caucasians versus the group that was more mixed. So that's why they saw a greater impact. So I've been kind of talking a lot about, we can show significant differences in how these drugs work, but it's been very difficult to have good prospective data to show clinical outcomes, and that's certainly one of the barriers I hope I've illustrated in these drugs. There's just little to drive these things forward into practice. And the testing can also be a barrier. A lot of these tests are relatively straightforward to do, but there's a cost, and it's most of the time the reimbursement for this testing right now is not very good. So I think really what's going to take to drive some of this into practice is really low-cost, massive scale screening methods that allow us to achieve these results at a very low cost. The turnaround time of the results can be very important. Again, I illustrated a bit of that with clopidogrel, where it's important to have that result early on to get them to make that dosing change. Otherwise, there can be an impact. There are some technical issues and testing. I'll just quickly illustrate this with the 2D6 gene. They're greater than 30 alleles, but in addition to sequence variations, we have examples of multiplication of functional alleles. There can be over 13 copies of this gene. There are examples of duplication of a reduced functional allele, in addition, not just wild type alleles. And then we can also see mixed haplotypes of alleles and also deletions. So certainly any testing method for this gene is going to have to account for copy number variation in addition to sequence variations. And this is just to quickly show that in those patients that have 13 copies versus 1, you can see the difference in the metabolism of a gene. So clearly the copy number affects how different drugs are metabolized. Other barriers include the IT structure that's needed to get this pharmacogenomic data into the laboratory information system in a way that can link the genotype to drug response. Remember, different genes can be involved in different drugs, so the interpretations are more complicated because the interpretation may depend on which drug you're going to use. So there's a whole issue about how this data should be in the clinical information system and how doctors would access it, how they would get the alerts they need to understand that the patient does have genotype information that can be used to adjust their dose. Then there's barriers of education, training the medical community that this information can be used and how to use it. And then there can be some societal barriers, but again, these are not as strong in the pharmacogenomic area. So in conclusion, I hope I've shown you the genetic variation of a known source of variability in a patient's response to drug. Clopidogrel and warfarin are good examples of how this genetic variation affects dose and can impact outcome. And that demonstrating clinical utility and the cost effectiveness and the guidelines and the algorithms are all barriers to this implementation. But I think pharmacogenomics is a great opportunity for these data-driven approaches to make sure that patients get a right drug at the right dose at the right time. I did want to acknowledge my collaborator, Dr. Phil Empey, who's the principal investigator of our UPMC pharmacogenomics project, for giving me insights and also providing me some of the slides in this presentation. Thank you very much.
Thank you, Dr. Bellissimo, for a very informative presentation. We do have a bit of time for questions. So as a reminder, you can submit written questions by typing them into the webinar's control panel. Dr. Bellissimo, in your experience, how frequently are you finding patients with the reduced metabolism for the CYP219?
Yeah, we're pretty much seeing what we expect from the population variance. Remember, we expect about 30% of people to have impaired metabolism. We do monitor those genotypes and allele frequencies in our population, and we're pretty much seeing them at the rate we see them. So you do, like I said, you see about 30% of people have that impaired metabolism.
And how quickly are you expected to provide this information to the physicians when they send you a sample?
Yeah, again, this is a very important part of this test. Right now in our study, I think we're our biggest problem is typically over the weekend. I would say we're getting those out for sure within 48 hours, and then during the we run that test 3 times a week. So we're right around 48 hours, and we do have a priority on those being completed and signing out on the day and signaling the physicians that those results are ready. I think ideally, this again would be, it's always going to be best if that information is available preemptively, because there are patients who leave the hospital and then they have to change their medications, and that's not ideal. So what we're really looking for is a way to again propose that if we use a very inexpensive screen for these markers that could be done ahead of time, then you wouldn't have to worry about this time lag, because otherwise you're trying to provide all these different pharmacogenetic results in a time period that may be very hard to provide and have the most clinical utility you can. Obviously, I think the best approach would be is that the patient comes in the hospital with an MI and they put in a stent, that information's already in the system for them to use, and right from the get-go they put them on the right drug, versus like possibly sending them home on one drug and a couple days later saying, oh, we're going to switch your drug. So yeah, so that I think faster is always going to be better in this case, and the most smooth workflow would be that it would be done ahead of time. But of course it's hard to get that paid for, because ahead of time there's no supposedly clinical need for it. So I think we have to show how having this information on hand impacts clinical outcomes and events such that it's worth paying for that ahead of time.
We do have another question. What, in your opinion, is the future of applying pharmacogenomics in oncology?
To oncology? Well, obviously, I mean, oncology is one of these areas where drug impacts and testing have the greatest approach. And I gave you some examples of drugs that work only in very specific instances, and the oncology field is really exploding in the ability to detect these different mutations that are in tumors. And I think as the more they discover them, there's actually lots of drugs that can be used against different targets that they're discovering that are there. So obviously that's a very big field. It was the biggest part of the pharmacogenomic field, and I think you'll continue to see a lot of those therapies in cancer being very directed at the mutation types people have, because a lot of times we discover they have one type of cancer and they get the generic drug, but when we do a deep mutation analysis on that cancer, we see that they have other markers that suggest they would respond to specific drugs, which at the time they're not receiving. So yeah, I think there'll be a lot happening in the oncology field.
Okay, great. We don't have any other questions at this time, and we're about out of time anyway. Thank you everyone for participating in this webinar. And shortly you'll receive an email from AGT that includes a link to an evaluation. Please take a few minutes to access it and provide your feedback on today's session. The webinar today was recorded and will be posted on the AGT website in the near future. We hope you'll join us for upcoming webinars over the next few months. We'll send out a notification to members once registration is available for our next webinar. We hope that we'll see many of you at AGT's 42nd annual meeting, which is in St. Louis, Missouri this year at the historic Union Station Hotel, and it's scheduled for June 14th to 16th. Thank you very much for joining us.